Good morning again, everyone. So it's my pleasure to be here for the first content session of the day on empowering and engaging families in long-term care communities with education, empathy, and support. Deborah Bakti. I think we can all agree that empathy and support go a long way in creating better relationships and communities. And there's no one better than Deborah to talk about this today. Deborah worked as an executive in senior care for 11 years. And during that time, she became a residence family member 3 times with her husband, her mom, and her dad. That life-changing experience inspired her to leave her corporate career and start a company, Think Breakthrough, to change and support relationships between families and organizations that assist families with the biggest concern in aging. Now what? Sure, you've all had that experience of transitioning to being a long-term care caregiver and being like, what do I do now? Deborah's latest book is aptly titled, Now What? It's written to support people with their emotional journey of becoming a residence family member and equip seniors' care homes to develop trusting and compassionate care relationships with their new family members. So without further ado, welcome to Deborah Bakti. Take it away.
Thanks so much, Sam, for the warm welcome, and so grateful for the opportunity to work with Family Council Ontario and all of you that are on the call today. As Sam said, we're going to be talking about this concept of being able to empower and engage families who have loved ones living in long-term care through that education and empathy and support. And I think before we get into that, we need to really acknowledge the reality of today's environment, considering, well, I kind of think of it as a large understatement to say the last few years has been a whole thing, right? I mean, globally, we've been going through this whole thing. And certainly when we have a relationship with the long-term care industry and having loved ones living in long-term care, or you may be a soon-to-be family member about to move your loved one into long-term care, it probably sometimes feels like this little graphic here. That you may be feeling like you've been walking on eggshells sometimes, like this little character in the middle. And the feelings of overwhelm and anxiety and burnout and pandemic fatigue is a real thing for people who work in seniors care, as well as for families and residents. And when I think about this and how all of us are experiencing varying levels of these types of emotions and challenges, what that does is it impacts the quality of the relationships that we have, right? When we are feeling overwhelmed and burned out and don't quite have the bandwidth. And this is relevant and true for all of you on the call, as well as people who work in seniors care. And for the purposes of today's session, we're going to be talking specifically about the relationship with you as residents, families, and people who work in seniors care. So when we think about it, the beginning of the relationship between families and care team members is the admission process, which usually starts when you have that conversation with home and community services and have your loved one on the list, and you select the homes that you are preferring. And then it leads to the actual approval, that phone call, and then within a few short days, you're moving your loved one into care. And there is this concept that I refer to as admission anxiety. And both families and residents have their version of admission anxiety, which we're going to talk a bit more about, but also the staff have a version of admission anxiety as well. And so to shed some light on what I hear from families, and certainly as Sam had mentioned, we moved my dad into long-term care in 2011, where he lived for 6 months before passing away. And I moved my husband at the very young age of 63 into long-term care because of a degenerative and incurable and very rare disease that he had. And he lived in long-term care for 4 years before passing away in 2015. And although it's almost 13 years ago, I can still remember how that day felt. And I'm sure for those of you on the call, if you think back to your admission experience, you can probably recall how it felt for you as well. So I want to share this video clip of a family member. Her name's Carolyn, and I met her on a town hall call and was just so captivated with her story. I asked if we could do a recorded interview that I would be able to take clips to share. And Carolyn moved her aunt into long-term care. And this is just a little bit, give you a little bit of insight as to what her admission anxiety kind of felt like.
I was struck by how cold the orientation or onboarding intake was. And I just thought, well, this is the way it is. This is the way it is. They can't do it any different. This is the way it is. So I felt very lost. I felt very lost. Like I am stepping into a whole new world. I know zero. And I think when you're in a world that you're so familiar with, you forget that people are lost. And I think I still have this expectation, maybe a hope that the new caregivers coming in, that the home can sort of revolutionize the way that we are doing intake, because I think it would help a lot.
Now, it really stood out for me with what Carolyn said, and perhaps you heard it as well, where she said, I felt lost, like I knew nothing, zero. And it was a whole new world for her. She had had no exposure to long-term care at all until her aunt required care, and then she stepped in as that family caregiver. And the other thing that was really interesting is how she just assumed, her narrative was, well, it's just the way it is. There's nothing that can be done. This is just how it works. And we're going to be talking a little bit about narratives and how helpful or not they can be. So when we think about, and with admission anxiety, I certainly, and I'm going to assume that all of you can relate to that admission anxiety that perhaps you felt in admission day. What I didn't know for the whole time that I worked in seniors care and as a family member is that staff can also feel admission anxiety. And it wasn't until I had a session, I have clients who I help to redesign the admission process, almost like what Carolyn said, if we can revolutionize. And a part of that exercise is doing what's called emotion mapping, which is a very fancy word for having conversations with people about how they feel at different points of the admission. And from the staff perspective, they can feel admission anxiety around meeting their new resident. They get paperwork that describes certain key clinical information, but not always is that paperwork accurate or up to date. And so sometimes there can be some surprises, or they feel like they're not quite as prepared based on what they saw in writing. The other area of admission anxiety is around meeting the family. They don't know the family. They worry and wonder, how are they going to be to work with? Are they going to, be easy to work with? Are there going to be challenges? Are they going to have expectations based on what they've read in the media that maybe aren't realistic? So there's some anxiety around that. And the third area is around the admission process itself. There are hundreds of moving parts for admissions, from the very beginning of the process right through to the 6-week care conference. And a lot of things, because of those moving parts that impact every single department, sometimes things don't always go perfectly well. And so we've got, I say, both sides of the relationship having a common ground of admission anxiety, just for different reasons. There's 3 gaps that I've noticed that contribute to the admission anxiety. And also when we're able to become aware of them and close those gaps, it helps to lessen that anxiety and actually help to make the beginning of the relationship a smoother process. Because I just want to remind ourselves that both the staff and the families have a shared goal or common purpose in mind, which is to provide the best possible quality of life and care for their loved one, the home's new resident. And so these gaps can actually impact on both sides. The first is what I refer to as the knowledge gap. So as you could hear in Carolyn's comments, she knew nothing, she knew zero. So her knowledge gap was huge as far as knowing and understanding long-term care and what to expect. Now, what Carolyn did know was a lot about her aunt, her likes, her dislikes, what she did for a living, what her interests are, all of that. And she also would have a good understanding of her family dynamics and dysfunction, because what family doesn't have a little bit of dysfunction that can impact in their relationship and in the home. So she has all of that, but the staff, they don't really know much at all about all the things that Carolyn's already aware of. What they do know is the things that Carolyn's missing. They know their home like the back of their hand. They know their people, processes, policies, protocols, programs. They know it all. So we've got where the staff have what the family really needs to know, and the family has what the staff needs to know. And that's where they're starting the relationship. And the thing with families that I think of it like this: families don't know what they don't know. And it's not their fault. And when I do training with care team members working in long-term care, I reiterate this: families don't know what they don't know, and it's not their fault. It's not their fault that they have an expectation that their loved one's going to get 24/7 one-on-one care, and that their loved one's never going to have a fall now that they're in long-term care. Right? Because they don't know what they don't know. And here's the opportunity to be able to close that knowledge gap so that they have a better understanding and feel better equipped. The next gap is what I refer to as the emotion gap. So we talked a little bit about how, and if you think back to your admission day, how you may have been feeling emotionally. I know for me, I had this whole conflict of emotions. I was feeling sad and a bit angry that this is what was happening, frustrated that I couldn't manage things better with having him at home and getting home care. I felt a lot of guilt about having to make that decision, and frustrated that I understood that this is what we needed, but it certainly wasn't what we wanted, right? I think it's safe to say that none of us think as we grow older that this is what we want to place a loved one into care, right? We would prefer, all of us would prefer, and I think it's 98% of Canadians want to age in place at home, and we would prefer to keep our health and our abilities intact. But that's not always the case. And so this emotion gap can create, contributing to those emotions that I referred to earlier of burnout and anxiety and stress and fatigue. And when I think about this, it reminds me of a story of a family member that I met a few years ago who had moved her husband into long-term care. And she had a great relationship with the home. She'd already been a family member for a few years. And one day she went in to visit her husband and was helping him and discovered that he was wearing a brief. And that was not part of the care plan. And in that moment, she just, after getting her husband settled and safe, she lost it. She went tearing down the hall. And this is her telling me the story, tearing down the hall, found the first nurse and just started on them about how inappropriate, and she didn't know. And she was pretty fired up, which understandably so. And the nurse did a great job of, let's find a room, we can talk about this. Took full responsibility that, yes, it wasn't in the care plan, it was their mistake. A staff member neglected to make the phone call, and they talked it through, and the nurse was able to explain the necessity behind this change. And when she was telling me this story, she said, you know, it's not about the brief. It was in that moment, the realization that he was declining. His health was getting worse, and having to face the reality that this was the trajectory that he was on. And it really speaks to this: staff are not just meeting the family, they're meeting your grief. And grief can be a complicated emotion. I've talked to lots of families who've said, well, I'm not grieving because my husband or my wife is still alive. And I was of that same belief as well, that it wasn't grief that I was feeling, until I did some work with a therapist. And she explained to me that there's all sorts of different types of grief. There's the anticipatory grief that we feel, knowing that, I mean, for me, it felt like Ty was having death by 1,000 cuts with the slow and continuous progression of his disease. And there's disenfranchised grief. And part of that for us was, I was grieving the life that we were no longer going to have, the future that we had envisioned as a married couple, raising our kids and growing old together, right? So this grief element, I think what Barbara realized was, it was the grief that was really sparking what she would say was a disproportionate reaction in the moment, because she was burned out and overwhelmed and having a hard time coping with everything. And then the reality of what was happening with her husband just came to light. I want to share another clip of Carolyn where she talks a little bit about the knowledge gap and the emotion gap for her. What has been the biggest shift for you as a result of working with the material in the Now What book?
Well, I didn't realize when we were coming into the home that we were coming into a home. We were coming into a home. We were not coming into really a clinical setting. My aunt, sometimes when she's not too lucid, she calls it a hospital. But we're coming into a home. And my sort of mindset was us against you. Like, we need to protect my aunt because of the negative things that we had heard in the media. The first 17 days, we didn't even get to go into the home because of COVID. My aunt had to be isolated. She ended up getting COVID, but she was asymptomatic. So she was okay. But, she had fallen a few times. And because I didn't understand anything about how the home worked, I didn't know who to go to. So I was going above the head nurse to the director of care, because that's what I had to do. I want to escalate it. You want the best. Right. So I was coming off very defensive and a little bit jalapeno-y, as you mentioned in your book. So that was my initial experience. And after a while, you start to settle in, things start to settle down. My aunt's medications got adjusted the way they needed to be. So then, we're starting to relax. And then really reading the book gave me some big shifts, understanding, like, I didn't even understand that. I should have known this, that staff were grieving the person that had been in my aunt's room prior to her. And I'm a very empathetic person. Once I clued in, because I didn't realize that the staff actually really cared. And the more I observed and the more I realized my aunt relied on her one main PSW and the relationship that they have, I could just relax and take a breath and say, and really observe and evaluate and think, like, how do I want to have any interaction that could be potentially tense? How do I want it to end well? Because I want it to end well for me and my aunt, but also for the staff, because I need to honor them as well. They're doing not only a work, they're doing, it's a gift. It's a ministry. I'm not even sure what you could call it. It's a life calling.
So Carolyn covered a lot there, and we're going to be breaking down some of the pieces that she talked about, like the narratives. She had her mindset of us against you, everything from the media. She was coming in like this, just ready to protect her aunt. And when she said, I didn't realize that the staff actually cared, that's another common narrative of, well, people who get paid to care don't actually care. And this was a few months after she moved her aunt in and was starting to build those relationships. So some of those narratives that she had, she realized were limiting beliefs and weren't actually fact. So, when we think about the other piece I want to just mention is there was this really interesting empathy exchange that she all of a sudden realized that, well, the staff also have their grieving. You've got staff who have supported residents that they've grown to really care for and love. And it's really hard for them when a resident passes away. And also, if they've developed these strong relationships with families, they're losing the whole family. And within 2 or 3 days, there's a new resident that's moving in that they then are wanting to build a new relationship with. The third gap is the identity gap. And I want to share this relational triangle that I have. It's also included in my book, Now What? Managing the Emotional Journey of Long-Term Care for Families. And in this relational triangle, you see at the top, at the center, is your loved one who is shifting identities to also become a resident in a long-term care community. And then we've got the family and the care team. I think my name is covering it. So that bottom corner there is the care team. So we've got this relational triangle. And as a family member, in my situation, I had about 3 years where I was managing all of Ty's care. We went through 27 different specialists and 5 different hospitals in 3 different cities. I mean, it was like a 3-ring circus, but I was managing it all while working full time. And our kids were 11 and 17 at the time that their dad got sick. And so I was used to being the controller and the manager of all. I don't know if any of you can relate to this, but that was certainly my experience. And now my husband is moving in. He is now a resident with a number of other residents, part of a community, building new relationships with residents and staff. And I now have this care team that I never had before. And I really wish that somebody had given me a new job description. I mean, I knew that I was Ty's wife, a resident's wife, but I didn't really put the dots together. And remember, I worked in seniors care, so I knew more than the average person, and I still was a bit blindsided by that. And that can really impact the relationship, particularly at the beginning. I met a family member, her name's Shirley, and she was talking on this call because we were, just talking about the identity gap. And she was sharing how she had moved her mom, who was about 98 and living with dementia, and she had been taking care of her mom all this time. And I just want to read a couple of excerpts from, we had this great call, and she just had this larger than life personality and was just really sharing openly and very vulnerably how she felt. She said that, she was reading Now What? It helped her to understand the other side of the coin when families are adjusting to placing their loved one into long-term care. She said, at first, all I could see when I visited mom was that they weren't caring for her the same way that I'd been doing at home. And your book brought to light that I wasn't the only one getting used to this new norm. I hadn't thought about the staff having to get to know mom and figure out how they could best care for her. Then this was about the 9-month mark that her mom had been living in care. And she said her relationship with most staff had improved considerably, and that she felt that her mom seemed quite happy in the home and she's getting the best possible care that the staff can provide, given the limitations of the healthcare system. But this is where she really kind of called herself out. She said, thanks again for writing Now What? It really helped me to get over myself and focus on the positives of what goes on in a long-term care home. It's not perfect, but they do a much better job of taking care of my mom than I could have now that she's at the age and stage where she's at and living with dementia. And so it was on this call that how she expressed it was, she goes, I think I was driving the staff absolutely around the bend. I'd be there going, why are you caring for my mom that way? She doesn't like it that way. That's not how I would have done it at home, and on and on. And she said, kind of like, I'm pretty sure the staff were doing their best just to, try to not roll their eyes in front of her. She was aware that there was this tension that was happening, and that empathy exchange happens when staff can recognize that for a family, this is a really hard transition, particularly if they've been used to providing all of the care and doing it fairly independently, but also an empathy exchange with the staff that they too are learning. And I think what Shirley got to the point of recognizing that even though the staff aren't providing the care the exact same way she did at home, the care is still working. It doesn't make it any worse. It's just different. And also recognizing, as her mom was going to continue on her journey with dementia, the levels of care were also going to change. And this really speaks to this idea that you're not giving up control of your loved one's care. You're taking on a new role as a partner in care. And that may sound subtle, but it's a huge distinction. And where we're not giving up the control, we are a partner in care. And that ability to build that trust, respect, and partnership with the care team that are skilled and equipped to be able to help manage, and in that shared purpose of provide the best possible quality life and care for your loved one, their resident. So when we think about the role of as family members in this relational triangle, I have 3 questions that I want to share that you could either reflect on yourself, or if you are helping with the onboarding of a new resident and family, these are some questions that can spark some conversation. And the first is, how will I choose to show up as a family member? Because it's always a choice, right? How do I choose to show up in this new community where my loved one is living, where people are working? How will I choose to interact with the care team members? Part of this relational triangle as partners in care, how can we agree and collaborate, and how we can work together for that shared purpose and common goal of providing the best quality of life and care for their resident, your loved one? And the third is, how can I respond versus react when issues arise? And heads up, there will be issues. I say this to families all the time, that socks will go missing, glasses may get broken. You're living in a community setting and things can happen. And I think it's best to be prepared for when issues do arise. How can we choose to respond versus react? And this really is about, how do we focus on the things that we can control? And the biggest thing that we can control is ourselves and how we show up in that relational triangle. Because these are all opportunities to make deposits into the relational bank account, is sort of the metaphor that I think of with this. Because I really have come to believe that when we start our relationship in the very beginning, going back to that admission process experience day, we're probably starting that relationship in a deficit. Families are bringing their loved one in. It's super stressful, all of that emotion that we're feeling. As I shared with you, staff are also feeling admission anxiety for their reasons of they don't yet know the resident, they don't yet know the family, they may feel like they're walking on eggshells, they're hoping that the process itself, everything goes together smoothly. So another common ground of having this anxiety or a bit of angst just for different reasons then can create this deficit. So it's really important from the very beginning, how are we choosing to show up? And this is the training that I also provide to care team members, because in this relationship exchange, it takes both parties to have that mindset and how we're going to come together. And it's like this quote that says, take responsibility for the energy you bring into this space. And this quote is attributed to a doctor named Jill Bolte Taylor. And she's a neurophysicist, and she studied strokes. And at the age of 37 or 38, she suffered a near catastrophic stroke herself. And while she was in hospital, she discovered that the part of her brain that was impacted by the stroke made her overly sensitive to people's energy. Like it felt like a physical assault on her. If somebody came into her hospital room and they were in a bad mood or feeling a bit frustrated or overwhelmed or anxious, she really felt it. And so she put this sign up to say, take responsibility for the energy you bring in this space. And I think that it's something that we can all benefit from thinking about. We may not have that same strong reaction that she had, but we do react and respond to other people's energy, maybe at a subconscious level. And so when we can be intentional with how we're showing up, it helps in that putting us in a better place to be able to make those deposits into a relational bank account. So it's like this question says here, what kind of energy and experience do you want to create with your loved one and care team members? Because how we're showing up, how we're coming into the home and the community, it actually impacts the culture of the home. It impacts everybody. And I can think of times when I was working full time, commuting an hour away, after a long day of work, swinging into the home to see Ty, knowing that I still had to get home to make dinner and feed the kids and all of the evening routine. I'm not sure that my energy was the best. And hey, this is a work in progress. We can't do it right and perfectly all the time. But I think having that at least awareness and intention can help us to choose to show up differently. So I want to talk for a little bit about narratives. And as we had talked about earlier with Carolyn, she had a couple of narratives coming in even before she stepped foot into the home. Us against them, right? All of the media stories, I've got to protect my aunt. People who get paid to care don't really care. So we can sometimes, well, first of all, we're human beings. We're story-making machines. We make up stories to make the world make sense to us. It's part of who we are, no judgment, right? It's when we are not challenging our narratives that we can get ourselves into a bit of creating stress for ourselves. And so as families can come in with narratives, so can staff have narratives about families. And in the workshops that I do, where I say to them, let's talk about some of those narratives. And some of them can be like, well, families can come in with really unrealistic expectations. They can sometimes be difficult to work with, and we're trying to do our best, but then they make all these assumptions, right? So this isn't about pointing fingers. This is about saying in any relationship, you're going to have two sides and two perspectives. And I strongly believe this relationship is so important to be able to understand each other's perspective and create that empathy exchange so that we can be on that same page, providing the best quality of life and care for your loved one, their resident. And when I think about narratives, you can think of it this way as well, that they can be limiting beliefs, assumptions, which don't always equal facts. And I'll share a story of where that I really saw this come to life. I was working with a group of homes and we were having a Zoom call, checking in about the previous week and any experiences or successes that they had. And Amy, one of the staff members, shared this story, how earlier in the day, there was a new resident moving in, a gentleman, and his family members were his two daughters. And a couple of the staff members came over to Amy and said, this new family, they're going to be a nightmare. They are going to be so difficult to work with. And they were so rude to us, and going on and on about this. And Amy's just sort of like, right, you can just imagine the ripple effect, the word's going to get out. And so she decided to apply some of the things that we had talked about the week previously. And she went over, introduced herself to the sisters, and her intention was be curious, just be curious, and just started asking them questions. And some of them was, so tell me a little bit about your journey coming to long-term care, and a few other, I would call them icebreaker questions. And then she made the choice to be vulnerable and curious. And she said, so I'm curious, what are you the most worried about moving your dad into our home? And that's what really broke down any of the barriers. Because the sisters, they kind of looked at each other, and one said, well, you know, it's been really hard for us because our dad is saying things that have never come out of his mouth before. And he's doing things that, quite frankly, are just really upsetting and embarrassing and really inappropriate. And so we're just assuming it's only going to be a matter of time that one of you are going to call us and say, you know what, your dad's just too much. We cannot deal with him. So you're just going to have to come and pick him up and find somewhere else for him to live. And Amy just did such a beautiful job of, first of all, validating them. And she said, I am so sorry. That must be so hard for both of you to be managing and seeing and trying to deal with. And relating to them as people, as human beings, and educating them to say, you know, what your dad is experiencing, it's not him. We know that this isn't him and the dad that you remember. This is the disease, and these are the expressions and the behaviors that are related to his condition, not him. And then further provided some assurance that, you know, we've got you and we've got him. And we have probably 70 to 80% of our residents who also have some form of behaviors or expressions that we provide support to on a daily basis. This is not new to us. And we are equipped to be able to provide the support with your help as a partner in care. And I just think it's such a powerful example of the superpower of curiosity and allowing yourself to be vulnerable enough to ask the question, because, you know, it's hard to ask a question that you're not sure what the answer is going to be. And we don't know what would have happened if Amy never had that conversation, but if the word got out that this was going to be a really challenging family, what that could have ended up transpiring into. And thankfully, that wasn't the case. And Amy was able to go back and educate her coworkers to say, they're not rude. They're struggling with the heartbreak of watching their dad decline. And they don't know what they don't know. And guess what? It's not their fault. So this idea of how we can rewrite the narratives to be able to better support the reality of this is our reality, our loved ones living in care, and we're needing to and wanting to be developing positive relationships to provide the best quality of life and care for our loved one, their resident. So as I mentioned, Amy really embraced this idea of curiosity. And as this graphic says, curiosity builds connection. There are actually so many different benefits of curiosity. Curiosity is a way to be able to shift perspective, just like Amy did, and shifting that perspective from the rude family, the difficult family, to here's a family that's just really struggling to cope and needs our support. Curiosity opens up the opportunity for learning new information and insights. And curiosity has this soft energy about it. It really, when you think about when you're genuinely curious and you're asking a question that you don't know the answer to, it's very open. And it invites non-judgmental conversation. In fact, it's difficult, if not impossible, to be curious and judgmental, or curious and angry at the same time. So the next time, and it may be later on today, that you feel angry or judgmental, then you can prime yourself to say, what if I were curious in this situation? And you can easily just shift it by going, like Amy did, I'm curious, or I wonder. And that gets our brain starting to think more from a place of curiosity. And I also want to say on the whole judgmental thing, as human beings, we are hardwired to be judgmental, as well as to give advice and gossip. Like, it's just how it's part of that. We're part of our tribe. That's what actually creates connection, but not in the most positive way. So it's no judgment about if you find yourself judging, right? We just do it, but it's an opportunity to kind of practice with that. It's like this expression that an old Stephen Covey quote, seek first to understand, then to be understood. And sometimes that takes just taking a beat, taking a moment, taking a breath to be able to reset ourselves so that we can then shift from that place of curiosity. The next thing I want to talk about is expectations. And when I work with homes, if they're wanting some support in strategizing how to, if they've had a friction family conflict that's happened, when we do a root cause analysis, invariably it's because of an unmet expectation. And here's the thing with expectations. This formula, disappointment equals expectations minus reality. So when you think about it, if you have an expectation that's up here, but the reality is here, the gap is where the disappointment lies. And I want to share a quote. If there's any Brene Brown fans out there, her latest book, Atlas of the Heart, she talks about disappointment. She says, disappointment is unmet expectations. The more significant the expectations, the more significant the disappointment. The unconscious, unexamined, and unexpressed expectations are the most dangerous and often turn into disappointment. In fact, the research tells us that disappointment is one of the most frequently experienced emotions, and it tends to be experienced at a high level of intensity. Like, that's a bit of a downer, isn't it? That disappointment is one of the most frequently experienced emotions and tends to be experienced at a high level of intensity. When we develop expectations, we paint a picture in our head of how things are going to be and how they're going to look. The movie in our mind is wonderful, but no one else knows their parts, their lines, or what it means to us. Disappointment takes a toll on us and our relationships. It requires considerable emotional bandwidth. So, when we think about it, having an expectation, in fact, I'll give you an example. I talked to a friend of mine a couple of weeks ago, and she and her husband, they've just moved his mother, her mother-in-law, into care. And she said to me, finally, it's all going to be good. She's not going to have any more falls, and we're not going to have to worry anymore. I said to her, okay, that's a bit unrealistic of an expectation. She's like, what do you mean? I said, first of all, you shouldn't say can't. It's not realistic to have an expectation that your mother-in-law is never going to have a fall ever again, even though she's in care. And it's also unrealistic to think that you're never going to worry again. I mean, even with the best level of care, we're still going to worry. We're caregivers. So that needing to adjust the expectation, because the level of disappointment that she would feel the first time that they get a call to say, your mother-in-law's had a fall, she's fine, but we just wanted to let you know. Now it's not going to be something that she would just think, well, how could that possibly happen? And the thing with expectations is that it's a two-way street. So we need to be clear on what they can expect from us and what we can expect from them. I think it's really important, and again, this would be something that I share with staff as well, is to have an expectations conversation. And in the Now What book, where there's the 20 misconceptions, that can be a place to start, because if you don't know what you don't know, it's like you almost don't know what your expectations are. So look at what some of those misconceptions are that could help. Now, I want to share a tool that I use with staff that you may find helpful as well when it comes to expectations. And it's called an expectation gap map. It's a pretty simple template, as you can see here, where we look at what are the family's expectations, what's the reality of the home, And what are some possible ways that we could adjust those expectations or the reality, right? Because if we got expectations and reality, we want to adjust so that they are closer together. So I want to just share, it's a simple example, but when I ask staff, what would you say are the top expectations that you hear from families that you would consider to be unrealistic or unachievable? So this one, and laundry comes up every single time. So this one says, laundry shouldn't go missing, right? That would be a family expectation, that we bring laundry in and it shouldn't go missing. The home reality is that they handle laundry for, in this home, 150 residents, and it's a complex system, and there is room for error. And on that note, I visited a number of homes while I worked in seniors care over the 11 years that I was there. And I was always amazed that they didn't lose more when actually seeing the complexity and the number of steps in the laundry process. So when we do the brainstorming of ways that we can adjust, they said, well, we could provide education to the families about the laundry process and could offer a tour of the laundry facility. And if a home's not able to actually provide a tour, I've suggested, well, could you take a video? Could you take some pictures? Like, families don't know what they don't know. And so being able to provide the education to better adjust any expectations and avoid some of that frustration that can come from disappointment. So we have covered a lot. I want to make sure that we have time for Q&A. We've talked about the admission anxiety and how both sides of the relationship can feel that admission anxiety. And we also talked about the different gaps, right? The knowledge gap, emotion gap, identity gap. And when we create awareness and have strategies around that, it can help to lessen some of the anxiety that we may be feeling. And then we talked about the narratives, and to think about what are the narratives that I may have. And there's an author named Lori Gottlieb who wrote a book called Maybe You Should Talk to Someone. And her quote is, we're all unreliable narrators, right? We've got our biases and our assumptions. So an opportunity to challenge those. And then looking at expectations and being able to say to yourself, are the expectations that I have, are they achievable? Are they realistic? Is there some conversations that I can have with staff to help with that? And as we talk about this building empathy and connection and support, with a lot of the work that I do, things really boil down to, it's not necessarily what's happened, it's how we feel about what's happened. And I can think of circumstances for the 4 years that I was a resident's wife, and there were some frustrating moments, and I had my jalapeno moments, but I also remember how I felt when I really felt that partnership and compassion and empathy, both empathy for the care team members who they just cared so much for Ty and his well-being, and the empathy that they had for me and our kids as we were going through a very emotional journey. And so it's this quote that I want to share with you that says, I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And this is an opportunity for us to remember how we want to choose to show up and be partners in care and empower ourselves and focus on those things that we have control over, our agency and our role as a partner in care and a loved one for their new resident. Also, just want to mention, I'm launching a new podcast called The Empathy Exchange, and it's a podcast for families and care teams. I really want to have a platform where both parties in this relationship are in the same conversation. So if that's something that's of interest, please, you can find it with this information here. And I will turn it now back over to FCO for the Q&A.
Hello, everyone. Great. Wonderful. Thank you, Deborah, for such an enlightening session and a great way to start off our event today. I'm just going to go to the Q&A or to the chat to see if any questions have popped up. So if you do have any questions for Deb, please feel free to enter them into the Q&A chat bubble. And that way you can let us know what it is you'd like to know. If there's something that she mentioned in her session that piqued your interest, then now's your chance to expand a little bit further in that. Ooh, how can family councils help new caregivers to set expectations? Great question.
Yeah, it is a great question. I think that because family council members, I'm going to say that a lot of them are more seasoned. When they're able to reflect back on what their beginning journey was and look through those fresh eyes, it helps them to be able to connect with families and relate to what they're going through. Sometimes we can almost forget when we've been in an environment for a few years, it just becomes second nature to us. But to be able to go back to that fresh eyes approach. I also think that it's fair to say, this is an emotional journey. And to be able to kind of like what Amy did was to be able to validate how they're feeling and build that relationship based on that and provide the education. There's a lot of resources that Family Council Ontario provides to be able to give them that kind of support.
This is a great question. So you spoke a lot about relationships with staff. Can you expand on the relationship with a resident who is able to express their needs and wants with staff? And what are some tips for residents in building strong working relationships with staff?
Yeah. So, I think that when you've got residents who can advocate for themselves and have those conversations, part of it is, and I'm thinking about the expectations for a resident to be able to say, these are some of the expectations that I have. Are they reasonable? Are they achievable? Is there something within the reality that we can change? I mean, I've heard a situation where a resident wanted to have basically grilled cheese every day. Okay, so outside of any of the dietary stuff, but it was really important to him. And the home was able to adjust the reality. I don't know if it was 7 days a week, but certainly they came to a place of compromise and he was happy with that. So he was able to advocate for himself versus the narrative, I can't eat what I want here.
Absolutely. So I know that there's been a movement to engage families and family councils and their voices in quality improvement. So the expectation gap map is really good for individual caregivers, but they wanted you to speak to, do you think it could be a resource that councils could use to collectively, I guess, brainstorm once they've identified that collective issue, identify that gap and engage in the conversation productively with home staff when it comes to resolving that issue and I guess engaging that gap with quality improvement or matching that gap with quality improvement?
I love that idea. And I'm going to take that idea as well when I do staff training, because part of the exercise, we have a group of staff and we're saying, what are some of these expectations that, my whole thinking is if these continually come up, let's build a solution. But what I love what you're saying is that you're creating a co-design team and being able to have, when you have staff and families and residents, if that kind of like what you described previously, to be able to have an open conversation right there, one of the byproducts of that is going to be that empathy exchange. Because if you've got staff saying, well, sometimes we find that, families have an unrealistic expectation about laundry being returned within 24 hours as an example, and we can do it some of the time, but not all of the time. Then you can have from a family perspective, they may say, well, then change it to 48, as long as we know what the expected time frame is. Don't set yourself up for mistakes, kind of thing. So I think using a template like that keeps it really pragmatic, and we don't get into the emotion of it. We're just being very factual about what is and what we can change. Yeah.
Wonderful. Thank you. So this is more of a comment than a question. So building relationships is more challenging when there's different staff working. So agency staff or different rotations of staff. There's a lack of consistency in who's working with the resident. So what is it that you might suggest, or what are some tips that families and residents can use to build relationships when there is kind of that ongoing rotation in staffing? So it's tough to create that connection.
Yeah. So the first thing that comes to mind is, I mean, part of it is we need to accept that this is a suboptimal time with the Health Human Resources Challenge. And so if we're able to go in and say, okay, this is our reality for now, then, you know, when I think about when there was different staff with turnover when I was in the home, I would usually try to make the attempt to approach them, introduce myself to them, and initiate the conversation. And it doesn't have to be long. And also at a time when it's not the nurse that's at her med cart, because that is not the best time, right? But I think when we're able to, and our body language, and we've got an approachable smile and that kind of thing, and not even attach it to a question or a concern, because I think the first impression is, I just want to let you know, I see that you're new here. How are things? This is a great home. Really appreciate your support. Whatever that is, it could be 2 minutes, but you're starting to build a connection and building into that relational bank account.
Great. Yeah, it's never challenging to even just smile or wave or gesture, do something to try and make someone who's new to in the home might be a little bit challenging.
And I think I just go back to when I would be swinging in to see Ty and trying to squeeze that in. And I'm sure that, you know, my face wasn't projecting like, right. I could probably look a little scary. It is almost that walking through the doors and saying, take responsibility for the energy I'm bringing in this space. Mm-hmm. If it's only for 15 minutes and I've got a million other things on my mind, but for that point in time, I can compartmentalize for that time I'm showing up.
Absolutely. And I guess sometimes maybe giving yourself a buffer of like 5 minutes to just get things out before you have to get into that mode, and then having time before you get onto the next thing to get rid of anything that you're taking out of that session is probably also built into your schedule of.
Yes.
Great question. So can you share a bit about what you've seen in terms of peer support programs to support new families through the transitions, like moving in or transitions in the person's level of care and caregiver supports that you've seen happening in long-term care homes?
Yeah, I've seen some homes that have adopted a family ambassador program. And so they have, and usually this is through family council because they've got the connections, is to have families that volunteer that they will be a family ambassador. So let's just take the admission day. The family is made aware that we have a family ambassador program. Would you like to have one of our current families do a reach out call and describe a little bit about how they can be of support? Because some families may be like, no, I've got to fly back to Alberta and I'm not going to be back, right? Like, we don't know. So we want to ask for permission. And then that family caregiver, it usually would be, okay, well, if it's okay with you, they can give you a call either this evening or tomorrow morning, because that first day and going into the second day is pretty stressful for new families. And if they say that'd be great, then that family member is calling, introducing themselves, and just providing a little bit of that validation and relating to them and a little bit of education, if that makes sense. Or the person may just be, I'm just so glad that I'm talking to somebody who knows how I feel, because nobody gets what I'm going through. Right. So I think something like that, and you can decide how formal that you want it. There's other homes that have conducted their monthly for any admissions, any families that have moved a loved one in over the last month or 2 months. They have an evening where they invite all of them to come in together. So that's another option that can be done. But I really do like that family ambassador. I kind of wish I had a family ambassador when I became a resident's wife.
Absolutely. And that does speak to, if you stick around for our sessions today, our session after lunch led by the Kipling Acres team will be speaking about a specific support program that they've implemented in their home. So the last question, so it's a question that if there's a consistent problem that's happening with a resident that family may understand, but again, there's transitions in staffing, what strategies would be helpful for families or for a family to indicate that they'd like the staff to connect and consult with them? So how can a family indicate that they'd like to be consultant when there's a consistent issue with the care for that resident, that they might have some insight on what's worked in the past to support
Okay, so
staff.
I just want to clarify, is that if there's something ongoing that they want to with the direct care provider, or is it they're wanting to connect with somebody in management?
I think in this case, it's more with direct care. So they're speaking the examples like peri care
Mhm.
and anxiety tied to peri care. So I understand like that's a very personal thing. So if you've got staff changing all the time with it, and if there's a certain routine or certain history that staff would be aware of because they've been engaged in that individual's care for a long period of time, how can staff communicate, I guess, tips to support staff who might be filling in or that transition in staff to make sure that the care is helpful and successful for both the resident and for the staff?
Okay, so this is communication between staff. Yeah. Well, first of all, again, I think it's having the awareness that this is an important issue. And I think that, again, goes back to, and this could be something family council is involved in. What do we find are those sticky points that can really go sideways? And if the peri-care and the changeover of staff occurs, what kind of process can be put in place to make sure that that knowledge transfer happens? And then assuring the family that this is what we have in place. We understand that this is a key, I'm going to say the word process, but level of care, right? That is, that aligns with our quality commitment. And, you know, that becomes it. You need to have the processes in place, and then how are those being measured and monitored, right? So that's a bit outside of my scope, but quality departments, this is what they do all the time. And to be able to check to make sure that this is working. And I would also say, get feedback from the direct care staff that are involved in it and get their ideas, because some of them have probably already created their own strategies that really could be beneficial for others.
Absolutely. Well, thank you so much, Deborah, for such a wonderful session to start our day off. I'm going to
Thank
head
you.
over to Sam, who's going to wrap everything up, and I'm going to pop off into the background. But
Wonderful. Deborah, as always, thank you so much for such a fantastic session.
Thank you. Thank you. Enjoy the rest of your day, everybody.
Wonderful. So I know that my takeaways from Deborah's session was family councils can help with that expectation gap. You can brainstorm at a meeting, ask people what they were most concerned about at any point in the journey, and be responsible for the energy you bring into the space. So thanks again, Deborah. Always a pleasure. And I know we've all learned much from you this morning.
Thanks so much, Sam. Appreciate it. Take care, everybody.
Take care. So now we are going to be moving into our first wellness break of the morning. We'll be joining back at 11:30 for our next session, which is Color Connections, Engaging Caregivers in the Vision of Person-Centered Care with Jennifer Cornell. So another can't miss session, and that's at 11:30. So you've got just about 12 minutes now to grab a cup of coffee, take a stretch, do whatever you need to support your wellness today. And we'll be back at 11:30.